Hello, dear students. We're going to discuss an important issue that unfortunately still affects a group of our patients that could have been saved, the detrimental drawbacks of this topic if they have been properly managed. We will discuss either immunization, RH conflict, and hemolytic disease of the fetus or of the newborn. So in 1901 began studies of blood antigens, blood transfusion, genetic inheritance of blood, use of blood type. Carl Landeister identified and named the blood group ABO in 1909, and he got Nobel Prize for this. In 1940, Landsteiner and Weiner identified an antigen present in blood from a rhesus monkey, which stimulates the product of an antibody when injected into rabbits. So firstly, red blood cells of rhesus monkey injected into rabbit's body, rabbit responded to antigen present on the red blood cells of monkey and formed antibody against the antigen. Then the immunized rabbit serum tested against human red blood cells. Then agglutination occurred in 45% of people, and they were called as RH positive. And no agglutination occurred in 50% of people, and they were called as RH negative. RH blood group system has not been detected in tissue other than red blood cells. As an immunization, it is a process by which immune antibodies are produced in a person by the entry of antigen of another individual of the same species, the former lacking the antigen. RH as an immunization occurs when there is a different RH blood type between that of the pregnant mother and that of the fetus. For example, negative mother and RH positive fetus. This is a simplified figure of red blood cells. The actual representation of the antigenesis is much more complicated. Simply, the blood group is identified by precedent of the antigens, whether it is A, B, or AB, or O, with no antigen is presented on top of it. And RH that simplified from it is just the antigen. And it's more antigens there, and we will talk about it in our lecture. As D is the dominant to D, only individuals who are double D or big and little d, so it's mean homozygote or heterozygote, express the D antigen and are D rhesus positive. Individual homozygotes for the recessive D are D rhesus negative, and their immune system will recognize the D antigen as foreign if they are exposed to it. Incidence of RH negative around the world between Chinese people and Japanese people, it's about 1%. North American Indians, 1 to 2%. Indo-Eurasian, 2%. India, 5%. African American, 4%. Caucasians, 15 to 16%. And Basque, 30 to 35%. RH antigen are lipoproteins confined to red blood cell membrane. RH blood group includes some 35 other antigens, in addition to 5 antigens. In RH positive persons, 45% are homozygotes for D, while 55 are heterozygotes. RhD is the most immunogenic antigen. Maternal isoimmunization. Among the antigens capable of causing maternal immunization and fetal hemolytic disease, the RH blood group system is the most common. In particular, the D antigen of the red Rh blood group system is responsible for the most cases of severe hemolytic disease. Rh immunization occurs when Rh negative female receive Rh positive blood transfusion or when Rh negative pregnant mother is exposed to Rh positive fetal red blood cells. So the bleeding of maternal antibodies to fetal red blood cell antigens leads to hemolytic disease in the fetus or newborn, characterized by hemolysis, bilirubin release, and anemia. The severity of the illness encountered by fetus or newborn is determined by a number of factors, including the degree of immune response elicited, how strongly the antibody bind antigen, the gestational age at which the diagnosis is made, and the ability of the fetus or replenish the destroyed red cells to maintain a HCT sufficient for growth and development. Antibody formation occurs in two stages: sensitization and immunization. Sensitization, small amounts of fetal blood cross the placenta and enter the maternal circulation during uncomplicated pregnancies, and particularly at synthesis events such as delivery. If the fetus is D rhesus positive and the mother is D rhesus negative, the mother will mount an immune response, sensitization, creating anti-D antibodies. Immunity is permanent, and if mother's immune system is again exposed to the antigen, large numbers of antibodies are rapidly created. They can cross the placenta and bind to the fetal red blood cells, which are then destroyed in the fetal reticuloendothelial system. This can cause hemolytic anemia and ultimately death, and is called rhesus hemolytic disease. A similar immune response can be mounted against other red blood cell antigens. The principal antibodies affecting the fetus are anti-C, anti-E, and anti-Cal antibodies. So on the erythrocyte, 85% of humans have rhesus factor. This rhesus factor, you can see like blue triangles on top of the erythrocyte. These humans who has rhesus factor, we call them rhesus positive. Only 15% don't have rhesus factor, so we call them rhesus negative. Rhesus factor is antigen, and to rhesus factor can be produced antitels. Antitels look like a grip in this picture. Antitel produced in organisms where rhesus antigen is foreign. For example, if I have rhesus factor antitels, if I have rhesus factors, antitels cannot be produced in my organism. But if it is rhesus positive organism and antigen is in some cases got into the body, then antitels will be produced. And what happened next? If antitel produced, they start to connect, to join to the rhesus factor. So antitel starts to join to the rhesus factor, and they join to the rhesus factor on the membrane of erythrocytes. So antitels join rhesus factor and cause lysis of erythrocytes. So erythrocytes starts to destroy. If lysis covers a large number of erythrocytes, then erythrocyte destroying will be decreased. It will bring to anemia, to hemolytic anemia, and all this state calls hemolytic disease. So erythrocyte level will fall, hemoglobin level will fall, and free hemoglobin will circulate in the body and damage organs. It can damage liver, kidneys, and veins. So, if woman is Rh negative and the fetus if positive, erythrocytes of fetus can pass through placenta to maternal organism. What happens if the erythrocytes of positive fetus pass to negative mother? In mother's body will start to produce antitels. These antitels can cross the placenta and can pass through placenta to the fetus. And this antitel pass to the fetus and destroy fetus erythrocytes. Fetus will have hemolytic anemia. Fetus will have hemolytic disease. And this process we call immunization or sensibilization. So normally, placental barrier don't let fetus blood mix with mother's blood. But in some cases, there can be break in the placental barrier. It can be for different reasons. It can be during pregnancy, it can be during abortions, it can be during deliveries. So even little amount of fetal blood, even little amount like 0.1 milliliter of fetal blood enter into the into maternal circulation, it can cause hemolytic disease of fetus. So cases, in which cases barrier can break, placental barrier can break. So it can be abortions, it can be ectopic pregnancy, during molar pregnancy, in antepartum bleeding, during procedures, different procedures which may be done during pregnancy, like amniocentesis or cardiocentesis or Hornig-Wheeler sampling. Also traumas, when pregnant women got traumas, and also during the deliveries, especially if we use forceps in deliveries or it is cesarean section, so there can be break in the placental barrier. So fetal-maternal hemorrhage as a reason of Rh immunization has been documented in 5% in the first trimester, 13% in the second trimester, 29% in the third trimester, and the highest, of course, at the time of the delivery. The risk of sentencing also depends on the quantum of the leak. So the more amount of the leak, there's a more high risk of sentencing. For example, if 5 milliliters and more, so it can be 65 and more % of risk of sentencing. As the immunization takes almost 6 months, first pregnancy is always not affected. Re-exposure to the antigen procedures, a rapid immunological response usually measured in days. So if antigens cross placenta, fetal erythrocytes start to destroy it and can cause hemolytic disease in the fetus. It can be anemia in the fetus, hepatosplenomegaly, Jaldins, and placentamegaly, and we will talk about it today. Also, it can affect the mother. It increases incidence of preeclampsia, polyhydramnions, big baby and its hazard, and PPH due to big placenta. Effects or mother Rh immunization is suspected in utero when mother develops polyhydramnion, preeclampsia, maternal syndrome, and postpartum hemorrhage, big placenta, and blood coagulopathy, how I told before. So one of the non-specific prophylaxis of isoimmunization is preservation of the first and subsequent pregnancies of Rh negative women. When it's come to management, we divide it in two groups. Rh negative, non is a immune, and Rh negative are the immune women. If a woman is Rh negative and the father is Rh negative, so baby will be Rh negative, and we will manage this pregnancy as a normal pregnancy. But if the father phenotype is Rh positive and the mother is Rh negative, so if the father is Rh positive, there's 50% father heterozygotes to 100% father homozygotes. Probability that the fetus will inherit one copy of the Rh gene and therefore Rh alloimmunization may occur during pregnancy. That is why if the father is Rh negative and mother is Rh positive and mother is Rh negative, in 2024 and 28 weeks of gestation, we check a mother for antibody screening. We do antibody screening. So we check the levels of antibody in the blood. If there is no antibody detected, then at 28 weeks of gestation, mother should receive anti-day immunoglobulin. It is the prophylaxis. And in 28 weeks of gestation, she needs to receive anti-day immunoglobulin if for some reason she did not come at 28-week gestation. So later when she will come, maybe 30 or 32 weeks of gestation, we still need to do this prophylaxis dose of anti-day immunoglobulin. And after the delivery, we need to do the second dose of anti-day immunoglobulin. We need to do this second dose after delivery during 72 hours. If for some cases it was not done after 72 hours, so it is still allowed to do 10 days after delivery. So in which cases we do in postpartum period anti-D immunoglobulin, if a baby is born and we check and we see that the baby is Rh positive and the mom, we know that she is Rh negative, so after delivery anti-D immunoglobulin must be done. But if we see that the baby is Rh negative, so there's no need to do the second dose of anti-D immunoglobulin. Sometimes additional prophylaxis may be done. It can be done in the first trimester, second or third trimester. The dose of immunoglobulin is different because of trimesters. If additional prophylaxis is done, we do it usually when we have bleeding during pregnancy. If women get, for example, trauma and we face with bleeding, so we can do additional prophylaxis. If the additional prophylaxis were done, so in 28 weeks of gestation, we still need to do our prophylaxis of anti-D immunoglobulin. Also, we have prophylaxis following abortions. The anti-D is detectable on embryonic red blood cells by 38 days from conception or 7 weeks of gestational age. Fetal erythrocytes can be found in maternal circulation after spontaneous abortions in up to 1/3 of women at risk, and the fetal red cells more than 0.05 milliliters can be detected in 26% of women. The risk of alloimmunization following spontaneous abortions is 1 to 2%, induced abortion 4 to 5%. Even the small dose of D-positive red cells can synthesize 3% of D-negative women, so anti-D is indicated. The total fetal-placental blood volume at 12-week pregnancy is 3 milliliters. A dose of anti-D immunoglobulin is 120 milligrams. For miscarriages or induced abortions beyond 12 weeks gestation, anti-D immunoglobulin dose is 30 milligrams or more than enough. If an Rh-negative woman has had a negative anti-D antibody screen during this pregnancy, antibody screening need to be repeated before giving anti-D at abortion. If a blood type and antibody screen have not been done in this pregnancy, it should be done at the time of abortion. Alloimmunization has been reported after ectopic pregnancies also. 25% of women with a ruptured tubal pregnancy have significant number of fetal red blood cells in their circulation, suggesting that anti-D is indicated. Molar pregnancies due to absent or incomplete vascularization of villi in complete hydatidiform mole and the probable absence of D antigen on the villus trophoblast, the risk of Rh alloimmunization in molar pregnancy is minimal. Anti-D immunoglobulin may be omitted when complete mole is diagnosed in non-synthesized Rh-negative mothers. Anti-D may not be omitted for partial mole or uncertain diagnosis. Also, additional prophylaxis of immunoglobulin may be done after amniocentesis during pregnancy, after corneal will sampling, or cardiocentesis during pregnancy. When it comes to postnatal prophylaxis, so immediately, how I told before, after delivery, anti-D immunoglobulin has to be done during 32 hours after delivery. So we need to do anti-D immunoglobulin if the infant is Rh positive. Then the during COMS test on umbilical cord blood is negative. This test reveals whether or not the infant red cells are converted by irregular antibodies. And the cross-match between anti-D immunoglobulin and the mother's red cells is compatible. So this is the dose of anti-D immunoglobulin for postnatal prophylaxis. Prophylaxis with postpartum anti-D immunoglobulin effective in reducing the risk of sensitization after pregnancy and in a subsequent pregnancy, irrespective of ABO status of mother and baby. If Rh-negative mother do not receive anti-D immunoglobulin prophylaxis after Rh-positive baby, the incidence of sensitization during the next pregnancy is actually high. It can be to 12 to 16% compared to 1.6 to 1.9% in mother who did receive postpartum prophylaxis. So anti-Rh immunoglobulin need to be given within 72 hours of delivery to a postpartum non-synthesized Rh-negative woman delivering an Rh-positive infant. Additional anti-D immunoglobulin may be required for fetal-maternal hemorrhage greater than 50 milliliters of fetal red blood cells. If anti-D is not given within 72 hours of delivery or other potential synthesized events, anti-D should be given as soon as the need is recognized. So it can be given in 10 days after delivery for up to 28 days after delivery, or other potential synthesized events. If women for some reasons refuse to take the injections, her refusal should be documented. Women who are already synthesized should not be given anti-D immunoglobulin. Women who have a weak expression of Rh blood group do not form anti-D and do not therefore require prophylaxis. It should be noted that anti-D immunoglobulin does not protect against the development of the other antibodies, which can cause hemolytic disease of newborn. So when it's come to Rh negative is an immunized woman, first of all, we need to determine determination of paternal and fetal Rh phenotype and genotype. If the father of the baby is Rh negative, the fetus will not be affected and further tests are unnecessary. If the father is Rh positive, it is necessary to determine if he is homozygote or heterozygote for the Rhd gen. Fetal Rh determination, if needed, genotype by Horning wheel biopsy or amniocentesis can be done. Phenotype can be determined by serological testing using fetal blood. More recently, non-invasive fetal Rhd blood typing has been performed using cell-free fetal DNA from maternal plasma. Accuracy is reported to be as high as 99 to 100%. If pregnancy shows a positive anti-D titer, and anti-D titer is 1 to 8 in the first affected pregnancy, it is often the cutoff value. When the antibody titer is less than 1 to 8, intervention is not needed. Titer greater than 1/4 should be considered Rh as allo-immunized. However, the threshold for invasive fetal testing varies at different institutions and generally 1 to 16 or greater because these titers have been associated with fetal hydrops. When the titer is more than 1 and 16, so amniocentesis can be done, and percutaneous umbilical cord blood samples should be considered. Assessment of severity of fetal anemia, non-invasive assessment. It's two-dimensional ultrasound. We have to establish the correct gestational age to guide invasive procedures and monitor fetal growth and well-being to detect fetal hydrops. So middle cerebral artery peak and systolic velocity has to be checked. And assessment of severity of fetal anemia, it can be indirect, it can be spectrophotometry using a specimen of amniotic fluid obtained by ultrasound-guided amniocentesis, and can be direct fetal blood studies using a sample obtained by fetal blood sampling. So, hemolytic disease of the newborn and fetus is a destruction of the red blood cells of the fetus and neonate by antibodies produced by the mother. Hemolytic disease of newborn is a condition in which the lifespan of fetal or neonatal red blood cell is shortened due to maternal alloantibodies against red cell antigens acquired from father. So rate of red blood cell destruction is accelerated, but ability of bone marrow to respond is normal. It was a major cause of fetal loss and death among the babies, newborn babies. When it comes to etiology of hemolytic disease, first of all, it's RH incompatibility. As I told before, it's hemolytic disease occurs most frequently, develops when a RH negative mother conceives a fetus with RH positive. So also ABO incompatibility can cause hemolytic disease of newborn. Mother has blood type O and the fetus has blood type A or B or AB. And other causes like thalassemia or autoimmune hemolytic anemia also can bring to fetal hemolytic disease. So how it happened? Once antigen-antibody interaction occurs, antibody-coated red blood cells are removed from the fetal circulation by macrophages of spleen and liver, which lead to anemia. Anemia limits the ability of the blood to carry oxygen to the baby's organs and tissues. In response to anemia, fetal bone marrow and other hepatopoietic tissues in the spleen and liver increase the amount of red blood cells productions. Babies respond to the hemolysis by trying to make more red blood cells very quickly in the bone marrow and the liver and spleen. Organs start to enlarge, so it causes hepatosplenomegaly. New red blood cells released prematurely from bone marrow and are unable to do the work of mature red blood cells produced mononucleated red blood cells, which is enabled to carry oxygen. As the red blood cell breaks down, bilirubin is formed. Accumulation of bilirubin in body tissue and fluid results in jaundice of newborn. Due to immature liver of the newborn and inability to conjugate, the unconjugated bilirubin result in the unconjugated bilirubin increasing and crossing the blood-brain barrier and cause kernicterus. So kernicterus, or we call it bilirubin encephalopathy, it is the result from high levels of unconjugated bilirubin in the fetus blood, which is more than 20 milligram DL. Because unconjugated bilirubin are lipid soluble and toxic, it can cross the blood-brain barrier and it will penetrate the neural and glial membranes, thus cause neurotoxicity. Patients surviving kernicterus have severe permanent neurological symptoms such as spasticity, choreoathenosis, muscular rigidity, ataxia, deafness, and mental retardation. So it is a picture of kernicterus. So newborn has yellow skin, eyes can be yellow, and bilirubin can affect the brain and cause kernicterus. As the fetus anemia worsens, the fetus accelerates red cells production. Liver and spleen increase in size due to increased production of red blood cells. As a result, portal hypertension occurs, causing the liver to reduce its albumin production. This in turn results in edema. So edema is abnormal accumulation of fluid beneath the skin. And we call this condition hydrops fetalis. So hydrops fetalis, baby born with edema and had a severe form of anemia. So clinical symptom of hydrops fetalis, it varies from mild jaundice and anemia to hydrops fetalis. Baby have ascites, pleural or pericardial effusions. Chief risk to the fetus is anemia. Extramedullary hematopoiesis due to anemia results in hepatosplenomegaly. And of course, there's risk during delivery and labor. a baby can have asphyxia or splenic rupture. And postnatal problems include asphyxia, pulmonary hypertension, pallor, edema, respiratory distress syndrome, coagulopathies, jaundice, and kernicterus, and also hypoglycemia. So when it's come to management of hemolytic disease of newborn, the treatment can be maternal treatment and infant treatment. Maternal treatment, it can be plasma exchange. It's widely used treatment of immune-mediated disease. This treatment is applied to the pregnant woman with high antibody titer or that has past history of stillbirth due to hemolytic disease of newborn. These procedures are effective in decreasing the antibody titer and quantity of antibody. Plasma exchange can reduce antibody titer up to 75%. Besides that, it's also used for a way to delay the need for fetal intervention that has been hydrops fetalis, in which before 22 weeks gestation in a previous pregnancy. Another maternal treatment is intravenous immunoglobulin. Intravenous immunoglobulin is made up from plasma isolated. This treatment used strengthen body immune system beside to treat immune deficiency. Intravenous immunoglobulin were found to decrease hemolysis, leading to reduction in serum bilirubin level. The immunoglobulin could act by occupying the Phe receptors of reticuloendothelial cells, preventing them from taking up and leaving antibody-coated red blood cells. This subsequently leads to decrease in the need for exchange transfusion. Treatment of infants, it can be postnatal, antenatal and postnatal treatment. Antenatal treatment, so management before birth, it can be intrauterine transfusion. Red blood cells are infused into abdominal cavity of the fetus and then absorbed into fetal circulation to avoid hydrops fetalis and fetal death. Intrauterine transfusion can be done as early as 17 weeks. In intraperitoneal intrauterine transfusion, needle is passed through the mother's abdomen and into the abdomen of the fetus by help of ultrasound imaging to determine the position of fetus and plasma. The risk of this procedure is now largely dependent on the prior condition of the fetus and the gestational age at which transfusion is commenced. Titer greater 32 for anti-D and 8 for anti-K, OR for fold increase in titer indicates need for analysis of amniotic fluid. The amniocentesis performed at 28 weeks if hemolytic disease in previous child. Amniocentesis performed at 22 weeks if previous child severely affected. And amniocentesis performed if maternal antibody increased before 34 weeks. And postpartum therapy, it can be phototherapy. It's actual treatment of choice. Phototherapy accelerates bilirubin metabolism through the process of photodegradation. The effective wavelength of light seems to be in 420 to 475 nm range. During photoisomerization, the insoluble form on unconjuncted bilirubin is converted into water-soluble form. This water-soluble form permits more rapid extraction without conjunction through the bile or urine of the newborn. But it may be not effective in hyperbilirubinemia secondary to hemolytic disease of newborn if the concentration of bilirubin rises at rate of 0.5 to 2 nanogram DL per hour. In these cases, exchange transfusions must be done to the newborn. So exchange transfusion done to decrease the level of bilirubin and prevent kernicterus of newborn. Exchange transfusion can help to remove baby's synthesized red blood cells. To provide compatible red blood cells adequate oxygen carrying capacity. Exchange blood transfusion can help to decrease the level of incompatible antibody in the baby. Full-term infants rarely require an exchange transfusion if the infant undergoes the phototherapy. The exchange transfusion is done if the total bilirubin level is approaching 20 mg/dl and continues to rise despite the baby undergoes the phototherapy. The blood should be reconstituted from fresh or negative packaged red blood cells cross-matched against the mother and type-specific fresh frozen plasma. So prevention, of course, is RH immunoglobulin. As the brand name can be ROGAM. It's immunization in pregnant women can be prevented by administration of this RH immunoglobulin. Anti-D immunoglobulin is a concentrate of anti-D prepared from pooled human plasma of D negative people who have been exposed to the D antigen and who have made antibodies to it. Significance of administration RH immunoglobulin prevents all immunization in D negative mother exposed to D positive fetal red cells. In the meantime, it protects mother from being sensitized to D antigen of fetal during pregnancy and after delivery of infant. So RH immunoglobulin suppresses mother immune response following exposure to D positive fetal red cells. It prevents the mother from producing anti-D, protects subsequent D positive pregnancy, but must be given each time the woman is pregnant with D positive fetus. So prevention of hemolytic disease, of course, first of all, determine RH status of the mother. If the mother is not sensitized, reduce the risk of rupture of future sensitization. If the mother is sensitized, determine whether the fetus is at risk and monitor accordingly. To prevent either immunization of yet unimmunization mother, give anti-RH immunoglobulin intramuscular at 28 weeks of gestation.